Hello, let's talk about lysosomal storage diseases, which are rare diseases typically affecting infants and children. Usually, also multiple organ systems are involved. Here's how I think about the different diseases in this SDL. Tay-Sachs and Niemann-Pick both present with cherry red maculas. They are the only two on this list in which you see a cherry red macula when you go to examine the eye. And the way that you tell them apart is that in Tay-Sachs, there is no hepatosplenomegaly, whereas in Niemann-Pick disease, the liver and spleen are enlarged. Niemann-Pick and Gaucher may get confused with one another sometimes because they both involve macrophages inside the bone marrow. You do a bone marrow biopsy, you see these enlarged macrophages filled up with lipids. And the difference between Niemann-Pick and Gaucher is that in Gaucher disease, the degree of bone marrow involvement is much more severe. You can start to see cytopenias as macrophages expand and occupy space inside bones. You can also see fractures in these patients and even osteonecrosis as the bone marrow involvement grows and grows and grows. So again, fractures, bone pain in Gaucher disease, you really don't see that in Niemann-Pick, but you do see macrophages in both if you biopsy the bone marrow. Then there's Hunter's disease, Hurler's disease, and eye cell disease. I group these three together because all three of them present with a coarse facies that's characteristic of these diseases. It's called gargoylism. There's typically a flattened, squat nose and a prominent brow. And the way that you tell Hunter's disease apart from the other two is that you look into the eyes of the patient and you see clear eyes in a patient with Hunter's disease, whereas in Hurler's and eye cell diseases, there's corneal clouding. And then finally, you can tell eye cell disease apart from Hurler's disease based on joint involvement. Patients with eye cell disease typically have some restricted motion at joints or arthropathies. A couple more very high yield principles. All of these diseases are autosomal recessive. The one disease that's associated here that's not autosomal recessive is Hunter's disease. That one is X-linked recessive. You really want to know that because they love to ask you the genetics question just to see if you can remember recessive dominant and which one is X-linked. And then finally, the Golgi apparatus is dysfunctional in all lysosomal storage diseases. Remember that the Golgi apparatus does protein trafficking. Specifically, you're going to put a mannose-6-phosphate tag on lysosomal enzymes that you make in the rough endoplasmic reticulum, and then you're going to send those enzymes, which are called acid hydrolases, to the lysosome, and that mannose-6-phosphate tag is what allows that enzyme to successfully lock onto the lysosome and go there and only there. Let's break apart these diseases one by one. Here's a question about Tay-Sachs. It's a 19-month-old boy. He's having seizures. There's no organomegaly, and there's a red spot on the retinas when you look in the eyes. So the red spot lets you know you're dealing with either Tay-Sachs or Niemann-Pick, but because there is no hepatosplenomegaly in this patient, it's pretty safe to go with Tay-Sachs for your diagnosis. And the enzyme that's knocked out in Tay-Sachs disease is called beta-hexosaminidase A. So right off the bat, all of these lysosomal storage diseases, the questions are simple and straightforward. They love to ask, what is the enzyme? They love to ask, what is the metabolite or substrate that will accumulate as a result of the deficiency? And the reason why they like to ask such simple questions is because there's a lot of different enzymes that could possibly be out. And so they know that students have a hard time kind of juggling these different variables. Here's another Tay-Sachs question. A 5-month-old male that has no bruising, no fractured bones, no signs of trauma, respiratory, cardiac, MSK, and abdominal examination are normal. And then you look inside the eyes and you see this finding on the lower right corner of the screen. That's a cherry red macula inside the eye. So because the abdomen exam was normal, there's no hepatosplenomegaly. Therefore, the enzyme that's deficient in this patient is once more beta-hexosaminidase A. Here's a 6-month-old male with a little bit of developmental delay, problems making eye contact. There's a normal abdominal exam, but cherry red spots on the macula. So again, cherry red spots, you're down to 2 diseases, Tay-Sachs and Niemann-Pick. Because there is no hepatosplenomegaly, you're going with Tay-Sachs. The question is, what's going to accumulate in this disease? And the answer is gangliosides. So very simple questions. You just got to tell one disease from the other. Here's Niemann-Pick, a 2-year-old boy with failure to thrive. He's got some developmental delay and he is not growing properly. The spleen is palpable. The liver is also large. they do an optic examination. Here's what you see on fundoscopy. Here's your cherry red macula. Not exactly red here, but understand that what you're looking at in the eye, whenever you look inside someone's eye, you're going to see an optic disc. That's the most important landmark for you on fundoscopy. The optic disc is this part that I've circled in green here that kind of looks like somebody is shining a flashlight from behind it. And that's where the nerve fibers of the eye all kind of come together to make the optic nerve. Man, I was looking for a much more impressive vocabulary word than come together. And so all the nerve fibers of the eye meet up in this one place. They form the optic nerve that goes to the brain. And then the optic disc is also where the different arteries of the eye enter the eye and then branch out to innervate or supply the retina. And so that's where you're seeing right there is the optic disc. Now understand the macula is a little to the side of the optic disc. And what the macula is it's the area in your eye with the very best vision. You've got a very high concentration of cones there, and therefore you do not have any nerve fibers running over the tops of these cones. That's what allows you to have very fine vision there. There's nothing in the way. And so because there's no nerve fibers in the way of this macula, that means that there's nothing to be affected by any lipid accumulation disease. Understand lipids build up in neurons. And so you see pallor around the macula, and this pale ring that you see around the macula is a bunch of neurons that have swollen up and become edematous because they've got a whole lot of lipids accumulating within them. However, the macula itself is unaffected because, again, there are no neurons covering the macula, and the macula itself is the cherry red spot. So that's a little bit of lowdown for what you're seeing there. Back to the Niemann-Pick question. The question is, what's the function of the enzyme deficient in this patient? And so Niemann-Pick, that's a sphingomyelinase deficiency. Easy answer there, converts sphingomyelin to ceramide. The way that you remember that is that when you were a kid and you picked your nose, right? Niemann-Pick, you're going to pick your nose with your sphinger, right? Like sphingomyelinase. And so sphinger, pick, a lot of stuff going on there. Easy to remember. So here's what the hepatosplenomegaly looks like on a child. They've taken a marker and drawn out the margins of the liver and spleen. And the reason why the liver and the spleen swell up in this disease is because macrophages are accumulating a lot of lipid trash inside of them. And so just about all macrophages in this patient's body have swollen up as they have grown in size due to the lipids therein not being able to be broken down by lysosomes. And so when the macrophages swell up, well, they get into the bloodstream and they have to pass through the liver and the spleen, which are reticuloendothelial organs, which filter the blood. And so if you're filtering blood and these large macrophages come along, they're going to block up the filtration system. And so that's going to increase basically fluid inside the liver and spleen and cause them to swell in size. So the hepatosplenomegaly is attributable to the large macrophages in circulation. Why are they large? Because in the case of Niemann-Pick, there's a bunch of sphingomyelin in them. Here's a 6-month-old female at the emergency department with abdominal distension. You look in the eyes and there's bilateral cherry red spots. Patient also shows mild delays in early motor and cognition milestones. There's elevated blood triglycerides. Ultrasound shows hepatosplenomegaly. Bone marrow shows foamy vacuolated large macrophages. And so what enzyme is most likely deficient? Well, because there's cherry red maculas and there's hepatosplenomegaly, you diagnose Niemann-Pick. Therefore, this is an acid sphingomyelinase deficiency. In Niemann-Pick, you can see these sea blue histiocytes in the bone marrow. And a histiocyte, that word just means macrophage. And so you know you're looking at a bone marrow here because you see a lot of blood cells, red cells, and white cells around this sea blue foamy macrophage. And so they don't always tell you that it's sea blue, but they at least tell you that there are large foamy macrophages in the bone marrow that clues you into a storage disorder. Here's Gaucher disease, which, like Niemann-Pick, also presents with these large, foamy, abnormal macrophages in the bone marrow. Now, for Gaucher disease, the buzzword is tissue paper macrophages. You know, like when you buy someone a really nice present, and you want to put some little tissue paper in the bag, you know, just to dress it up, make it look nice. And so the differential for Gaucher is Niemann-Pick, because you see the macrophages in the bone marrow, but you're going to differentiate Gaucher disease based on the degree of bone involvement. In Niemann-Pick, patients don't have fractures most of the time. They don't have osteonecrosis, but in Gaucher disease, look at what can happen to these bones. Here is the head of the left femur that's getting some avascular necrosis in it. You can tell that this femoral head is very, very dark on x-ray. That means it's got a little bit of fluid in there. It's kind of empty, right? And so that bone is turning necrotic. Compare that to the femur on the right side, which is relatively normal. And then what you can also see in these patients is cortical thinning. So here on the left side of the screen, this is a normal, healthy femur, and on the right side you can tell that the cortex, which is the outermost layer of bone, which is what gives bone its strength, that cortex is kind of thinned in size as macrophages inside the bone marrow have proliferated and expanded within that marrow cavity. And so this predisposes patients with Gaucher disease to fractures. It could be the long bones of the leg, it could be the vertebral column. A lot of different bones are involved in Gaucher disease. That's my big takeaway. The bones are always involved. Let's look at some questions. Here's a 6-year-old boy with severe pain in his right hip. It was a sudden onset. The boy has not been able to walk since it began. He has been seen in the emergency department previously for bone pain, but there's been no conclusive diagnosis made yet. 1 year ago, he did undergo emergency surgery for a splenectomy after following a ruptured spleen. And so they tell you that the spleen ruptured, so that's the hepatosplenomegaly component. So Niemann-Pick might be on your differential, and it is indeed an answer choice down here, but because of the degree of bone involvement, it's very extreme here. Multiple fractures, avascular necrosis, you're going to go with Gaucher disease. And so this is just simply what's the diagnosis. And when it comes to lysosomal storage diseases, you do tend to get a lot of what's the diagnosis questions. Here's a short and sweet. 15-year-old male with bilateral hip pain and avascular necrosis of the femoral heads. You take a bone marrow biopsy and you see clusters of histiocytes with fibrillary cytoplasm. That's that tissue paper appearance, and it's going to stain periodic acid shift positive. And so again, what's the diagnosis? Gaucher disease. Hurler syndrome. Hurler syndrome, Hunter syndrome, eye cell disease. These are 3 diseases that present with a characteristic coarse facies with kind of a flat, squat nose and a little bit of brow prominence. Hurler disease, you're going to be able to tell this one apart from Hunter disease because Hurler disease has corneal clouding. Look at this patient's eye, and you can kind of tell there's a little bit of a gloss or a haze over it. Kind of like if you go outside to your car and it's a very cold morning, and maybe because of the morning mist and dew, your windshield is a little bit frosted over. So, you take out the scrape it off, and get on the road. And so that's what this patient's eyes look like. Kind of look like if you sprayed a little Windex on there and wiped it down, then all that clouding would just go away. But please don't try that. So that's Hurler disease. You see corneal clouding. Hunter disease, however, you do not. There is a great first aid mnemonic. It says hunters see clearly and aim for the X being the target. And that mnemonic works because hunters is X-linked recessive. You really want to remember that because this is just about the only, there's 2. There's Hunter and Fabry disease. Hunter's is the only one touched in this SDL that is X-linked recessive. So how does Hunter's present? Here's a 2-year-old boy with progressive hearing loss, prominent forehead, hepatosplenomegaly, and lab analysis shows a deficiency in iduronate sulfatase. And so this is an enzyme that degrades glycosaminoglycans. And so this patient would present with increased dermatan sulfate in the blood and urine, as well as increased heparin sulfate in the blood and urine. And that is heavily diagnostic for Hunter's disease. And so question is simply, what's the diagnosis? And so you see, they give you the enzyme. They do this frequently in these questions because there's a lot of diseases with a lot of enzymes. And even when they give you the answer, a lot of people will still get it wrong. So they give you the enzyme. Make sure you know the enzymes and the accumulating products. Here's a 4-year-old boy with coarse facial features. They literally always tell you that for Hunter syndrome, Hurler syndrome, eye cell disease. They always tell you coarse facial features. He's got a prominent forehead and he's got a flat nose. And then it tells you that the boy's got a family history of a lysosomal storage disease. So the question is, what's the kid deficient in? Well, you see that coarse facial features is only going to be seen in that Hunter, Hurler, eye cell triad. There's only one disease out of these 5 answer choices that fits that, and that's iduronate sulfatase. That enzyme is again deficient in Hunter disease syndrome, which is X-linked recessive. Here's a 2-year-old male with ear pain. Parents are concerned because he has recurrent infections. He's got macrocephaly, coarse facies every single time, coarse facies, and hepatosplenomegaly. And in this question, they gave you a pedigree and they said, what enzyme is the kid deficient in? So then you look at the pedigree and you see that only male members of this family are affected by the disease. Therefore, you know that you're dealing with the lysosomal storage disorder that is X-linked, and that would be Hunter disease. Therefore, you choose iduronate 2-sulfatase. Again, what do you see in the peripheral blood? Heparin sulfate, dermatan sulfate, your glycosaminoglycans. Here's eye cell disease, which is the very last one I believe covered in this SDL. Eye cell disease, I stands for inclusion bodies, and particularly you get inclusions in fibroblasts. And so this lends itself well to memory because fibroblasts, right? It's that similar vowel sound in the middle of fibroblasts, eye cell disease. And again, they love to ask about the Golgi apparatus because eye cell disease happens when you have a problem, specifically putting that mannose-6-phosphate tag on glycoproteins, thus localizing them to go to the lysosome. The enzyme that's deficient is this N-acetyl glucosamino 1-phosphotransferase. That's NGPT or something like that. So you want to know that patients with eye cell disease have coarse facial features and clouded corneas. Therefore, your differential for this is Hurler syndrome, which also presents with coarse facial features and clouded corneas. So you can see how you can easily get these two confused with one another. The big difference is that in eye cell disease, number 1, there's a problem with fibroblasts. They like to tell you that. Number 2, there's restricted joint motions. Patients will have arthralgias, maybe joint pain, maybe flexion contractures, maybe like their arm is stuck on bend or flex, eye cell disease, here's a question. 18-month-old African-American boy with coarse facial features and corneal clouding, along with hepatomegaly. So it's up in the air. They got to give you a little bit more than that. But then they tell you he's got limited mobility in both the elbows and knees. This is what tells us this is eye cell disease rather than Hurler disease. They give you a little bit more. They say that fibroblasts on electron microscopy show vacuolization and cytoplasmic inclusions. Therefore, you diagnose eye cell disease. The question is, what defect is associated with this patient's most likely condition? Going back to our knowledge, we know that eye cell disease is a problem putting that mannose-6-phosphate tag on lysosomal enzymes in the Golgi complex. That's exactly what gets asked here. One more question. An 18-month-old girl with a rare disease is brought to a genetics clinic. She's got club feet, coarse facial features, and enlarged gums. The geneticist explains that this child's disease is caused by the failure of a process that occurs in the structure indicated in the image below. So we zoom in on this, and even if you didn't make the diagnosis of eye cell disease, you can at least tell that we are not looking at a rough endoplasmic reticulum. We know that because there's not any ribosomes stuck onto the wall of this structure. These ribosomes would appear as tiny little black dots all over, again, the folds or the walls of this structure, this organelle, if we were looking at the rough ER. However, because there are no ribosomes, we're going to go with the Golgi. And the question is, the organelle pictured is essential for which of the following processes? Understand that the Golgi is the post office of the cell. It modifies proteins and then ships them to where they need to go in the cell. Maybe that's the cell membrane. Maybe that's the lysosome. Maybe it's just the cytoplasm. Point being, the Golgi is where proteins leave their site of production and mobilize to wherever they need to be to fulfill their function. So that's a lot of practice questions there. I'll go ahead and go through this SDL right quick. Talking about lysosomes here, we start off with just what is a lysosome? And it's essentially, the wood chipper of the cell. It just takes all these proteins and lipids and reduces them to 1-2 carbon components that are just very easily digestible. And so the lysosome does this via these enzymes called acid hydrolases. And that name acid lets you know that this hydrolase, which cuts apart proteins and lipids, likes to operate at a low pH. Therefore, the lysosome maintains a low pH by virtue of proton ATPases, very similar to what you see on the intermitochondrial membrane at the end of the electron transport chain. SDL also tells you that lysosomal enzymes are localized to the lysosome by virtue of a mannose-6-phosphate tag that they acquire in the Golgi. This is a very high yield testable point. Some more overarching principles. You do tend to see weird macrophages in lysosomal storage disorders, especially Gaucher disease and Niemann-Pick disease, and that's because macrophages have an abundance of lysosomes. If you have a lysosome problem, the macrophages are going to be some of the first cells hit. You really want to understand that all of these diseases are autosomal recessive except for Hunter syndrome and Fabry disease. That is very, very important. You will see a question on that, whether it's on a practice test or the real thing. Big chart. My big takeaway is that 2 of these, again, are X-linked. Hunter's X-linked recessive, Fabry X-linked dominant. We talk about Tay-Sachs. Beta-hexosaminidase A is the enzyme that's deficient. What accumulates? GM2 ganglioside. You need to know both of those. You need to be able to match them to the disease. How do you recognize Tay-Sachs? There's a cherry red macula. There's no hepatosplenomegaly. Patients typically have failure to thrive. Motor dystonic symptoms, motor neuron symptoms. And neurons are hit hardest by this disease, which is what we can attribute the motor and mental deterioration to. Niemann-Pick disease, similarly to Tay-Sachs, you see a cherry red macula. Unlike Tay-Sachs, you see hepatosplenomegaly. That's what makes the diagnosis. This is a sphingomyelinase problem, and so sphingomyelin is the substrate that accumulates in Niemann-Pick disease. Remember, you pick your nose with your finger, and you do see sea blue foamy histiocytes. If you do a bone marrow biopsy, they don't always tell you sea blue, but they do always tell you that in the biopsy, macrophages are large and foamy. So then we'll talk about zebra bodies on electron microscopy. That's not really a testable point. That's more of a non-specific finding that the writer of a question would only include if they were trying to push you in the direction of a lysosomal storage disease. There is a Niemann-Pick type A and type B. I want you to understand that you're thinking type A Niemann-Pick until proven otherwise. This is way too specific really for a boards exam, but maybe you could see this on in-house. Type B Niemann-Pick shows pulmonary involvement with a way later diagnosis. You don't normally catch this in infancy. Whereas type A, again, symptoms are fulminant within the first 2 or 3 years of life. If you have type B, your lungs are involved. You do not have neurologic involvement. So these 2 diseases are very, very opposite in many ways, or subtypes of the disease, rather. Then there's Gaucher disease. The substrate is glucocerebroside. The enzyme is glucocerebrosidase. Easy to remember. They all start with G's there. Gaucher disease is characterized by bone pain, fractures, avascular necrosis. The bones are big time involved in Gaucher disease. You see tissue paper macrophages. I think in the question that was described as fibrillary processes inside the cytoplasm of them. You might also see cytopenias. So that's just a drop in red cells or white cells or platelets, or if it's all 3 blood cell lineages, that's called a pancytopenia. And that can occur anytime you have a disease process occurring in the bone marrow because your circulating blood cells are produced in the bone marrow. Therefore, if you have something like Gaucher, in which a bunch of macrophages are expanding, growing in size, and taking up space in the marrow, then you're going to see a proportional decrease in the rest of your red cells, white cells, platelets, as that bone marrow is continually taken over. So again, hepatosplenomegaly, the cytopenia can also be caused by hypersplenism. So you can get a drop in circulating cells whenever the spleen gets enlarged, First off, why would the spleen get enlarged? The spleen would get enlarged in Gaucher disease because these macrophages are very large and the spleen is a filtering organ, and these macrophages become so swollen that they can no longer fit through the filtering capillaries of the spleen. So then they occlude splenic capillaries, and this causes an increase in basically the pressure of blood within the spleen, which leads to more filtration. And when there's more filtration, and when these macrophages are plugging up the filtration system, platelets and red cells and white cells get stuck in the spleen. So that's how you get your cytopenia and Gaucher disease, along with the whole bone marrow thing. Then there's your mucopolysaccharidosis. I don't like how this SDL calls it mucopolysaccharidosis type 1. You know, nobody calls it that really. You're going to call this Hurler syndrome, right? And so you remember that Hurler syndrome is autosomal recessive, and that patients are going to have corneal clouding, and that's how you tell it apart from Hunter syndrome, which is X-linked recessive. You also remember Hurler syndrome characteristically has coarse facial features. They always tell you that. And some dwarfism can be observed sometimes. Maybe the patient will have a heart problem later on down the line, but really that coarse facies is going to clue you into, I'm dealing with Hunters or Hurlers, and then you're going to make that differential based on the corneal clouding. And also don't forget eye cell disease, although very, very rare, can be in that differential for coarse facies and corneal clouding. So a big point that gets mentioned 2 or 3 times in this SDL is that dermatan sulfate and heparin sulfate accumulate in the blood and in the urine of a patient with Hurler disease or Hunter disease. And so dermatan sulfate, heparin sulfate, these are glycosaminoglycans, and they function essentially as molecular springs or shock absorbers because they've got a lot of sugars which are polar, and thus they attract water. And so these molecules sequester a lot of fluid within them, which gives them a compressibility, because if you squeeze them, they'll, like a sponge, squeeze the water out of themselves. And so there's room for them to shrink and expand. So dermatan sulfate, heparin sulfate in the blood and urine, that is diagnostic for this Hurler syndrome. What's the enzyme that is out in Hurler syndrome? You really got to know that. That's alpha L iduronidase. And Hunter syndrome has an enzyme that also has iduronate something in it. I can't remember it off the top. Maybe it's iduronidase 2 or something. But Hunters and Hurlers, really like flashcard that, Anki that, keep them separated because they're really, really similar. And then finally, eye cell disease, the last one in this SDL. You want to recognize the enzyme is N-acetylglucosamine 1-phosphotransferase, or NAGT, which is normally found in the Golgi. It catalyzes the first step in the synthesis of mannose-6-phosphate recognition markers. Therefore, if you can't put a mannose-6-phosphate tag on acid hydrolases, then you're going to have an empty lysosome that's not working. And if you have an empty lysosome, then that's how you get the accumulation of various substrates inside cells. So patients with, again, I'm not a fan of how they call it mucolipidosis 2 and 3. You know, you're not going to see that in first aid. You're not going to see that in pathome. You're not going to see it on the boards. If you do, it's going to be called eye cell disease. Okay. And so eye cell disease is ML2, I believe. There is this little section talking about differences between ML2 and 3. ML2 has a very severe fulminant prognosis with early death. ML3 is attenuated with more mild symptoms and features and prolonged survival as usual. That's about the best that they give you to go off of. I don't think you would ever get asked about that, but there it is if you do. And then what you really want to know about eye cell disease is that the inclusions are in fibroblasts. So eye cell, fibroblasts. Again, that same vowel sound, easy to remember. You might see zebra bodies on electron microscopy. And the electron microscope, I'll end by saying that's what we pull out when we have absolutely no clue what this disease is that we're dealing with. You pull out the EM as the last resort. And so it's for very rare diseases only. And all of these lysosomal storage diseases are certainly rare diseases. So that's what I got. Thanks.